Thank you so much for joining us, everyone who's here live and also who will be watching the recording of this talk later on. This is our weekly seminar series for the Center for Healthcare Policy and Research. We also offer the seminar series as a graduate seminar in public health, as continuing medical education credit for clinicians, and also just for anybody interested in some of our applied topics in clinical research, community-based research, and policy research. So we're just really grateful for all of you for joining. I also am pretty sure this is the last session for the winter quarter. Can't believe it. For this academic year. So thank you all for sticking with us. Today, we are super, super fortunate to have an expert who's going to come talk to us about community violence interventions, Dr. Shani Buggs. Dr. Buggs is an associate professor with the Centers for Violence Prevention at UC Davis Health. She's also a professor in the Department of Emergency Medicine here. And she is really going to lend her public health and health policy expertise to think about multi-level drivers of violence and safety, firearm violence prevention, and community level prevention, which I think is the focus of her specific talk today. So I know you've worked on a lot of really amazing projects, Dr. Buggs, and I'm just really excited to hear some of your more recent things with us today. And I know you're really excited to get into Q&A session with us at the end of your remarks. So really, really appreciate you taking the time, and I will pass it over to you.
Yes, thank you. Good afternoon, everybody. Thank you to the Centers for Healthcare and Policy Research for the invitation to present. And as stated, I am talking today about person-centered approaches to interrupting violence, which is known in the field as community violence intervention, and I'll get into that. No financial conflicts to disclose. Um, and just to give an overview of how this talk will go, I'm going to start with some definitions just to make sure that we are all on the same page when I use particular words, you know what I'm talking about. Um, and then talk a little bit about structural drivers and consequences of interpersonal violence, because I think that that really helps to foreground why person-centered approaches to interrupting community violence or CVI approaches are really key to addressing interpersonal violence. I'm going to talk a bit about the UC Davis Wraparound program, which is a community violence intervention approach, and get a little bit into some of what we found in an evaluation of that program, and then end with just some high level advice for healthcare providers and CHPR scholars. So first, definition of violence. The World Health Organization, in its 2002 World Report on Violence and Death, defined violence as intentional use of physical force or power, threatened or actual, against oneself, another person, or against a group or community that either results in or has a high likelihood of resulting in injury, death, psychological harm, maldevelopment, or deprivation. Um, so I think it's important to note that besides death and injury, this definition also includes perhaps less explicit consequences of violence, like psychological harm, abuse, neglect, and deprivation. In the same report, the WHO also defined community violence as intentional acts of interpersonal violence among individuals who are not intimately related, and that often occur outside residential dwellings. And community gun violence or community firearm violence is that which is committed, like community violence that is committed with a firearm. The vast majority of lethal community violence in the United States, over 70%, is firearm community violence or community firearm violence. But this phrase, community violence, really belies the systemic nature, the systemic drivers of this type of violence. When we think of violence, we typically think of it as requiring three elements. There is an action or the harm itself. There is an object or the tool that's used to cause the harm. And then there's an actor or the person doing the harm. But when we have systems, policies, and practices that deprive certain communities, particular communities, intentionally depriving communities of meaningful opportunities that are critical for safety and health, we have what's known as structural violence, which was defined in the 1960s by Norwegian psychologist Dr. Johan Galtung as the avoidable impairment of fundamental human needs or the impairment of human life, which lowers the actual degree to which someone is able to meet their needs below that which would otherwise be acceptable, and where there is no individual actor. And it was described by Dr. Paul Farmer and colleagues as social arrangements that put individuals and populations in harm's way. And it's important to think about the ways that structural violence, structural drivers contribute to inequities and conditions that help lead to violence that we see today. So this is a conceptual model that was developed by the Prevention Institute and the Advancement Project in Los Angeles. And I like this model because it highlights in pretty straightforward terms a number of ways that interpersonal violence at the community and population level impacts health outcomes and the ways that the structural violence contributes to inequities and conditions associated with violence. So, at the structural and societal level, you have drivers such as the lack of government accountability in addressing inequitable distribution of opportunity, resources, money, and power through actions such as historical redlining, economic and residential segregation, eminent domain laws and policies, racial and ethnic disparities in employment, perpetual or worsening income inequality, the racial wealth gap, and more. You have societal level blaming, criminalizing, and dehumanization of populations of people based on their racial, ethnic, or cultural differences. You have a lack of health and safety prevention infrastructure and an over-reliance on punitive and suppression strategies to deter or in response to interpersonal violence. And then the structural drivers contribute to what we know as the social determinants of health and safety, lack of economic opportunity, disconnected and isolated families, community deterioration and trauma, substandard schools, cycles of mass incarceration, and a sense of hopelessness that can permeate through communities where there are these high rates of violence. And those contributors and consequences can and do lead to both the fear of violence and violence itself. And the real and perceived fear of interpersonal violence helps to drive a lack of community safety, which then further exacerbates the structural drivers of violence and causes this cyclical effect. And it's well documented that violent injury and death leads not only to mental health problems and substance abuse, but also barriers to healthy eating, active living, and optimal quality of life. And all of these contribute to high rates of chronic illnesses in communities suffering from high rates of violence. So, what do we know about community violence, community firearm violence? Well, one of the things that we know from the data, um, as well as from experiential expertise from the people who live in communities where interpersonal violence is pervasive. We know that community firearm violence is systemically and highly concentrated among certain populations and in certain places. And these next few slides focus on firearm related homicide, particularly because, as I said, the vast majority of lethal community violence in the United States is community firearm violence. So this graph shows the overall firearm homicide rate in the United States from the years 1999 to 2021. Um, and you can see that the rate increased from 3.88 per 100,000 people in 1999 to 6.32 per 100,000 people in 2021, with a notable increase since 2014. Um, but this does not reflect the disproportionate impact of gun homicide, the concentration in certain populations of people. This graph adds in the firearm homicide rate for all Black individuals, regardless of sex. And you can see that the scale of the graph has changed dramatically. Um, African Americans in 2021 were dying by firearm homicide at a rate that was over 4 times that of other Americans. And this graph adds in the firearm homicide rate for all Black males. Again, notice the scale change. And this adds in the rate for Black males ages 15 to 34, who in 2021 were dying by gun homicide at a rate that was 17 times that of the overall population in the US. Firearm homicide is the leading cause of death for Black males in this age group and has been since the 1980s for over 4 decades. The gun homicide is also the second leading cause of death for Black females ages 15 to 24 and Hispanic males ages 15 to 24. And it has been for years. So it's important to just, I think, let that staggering and abysmal statistic kind of set in, those statistics set in, because we think about the thousands of lives lost, and the thousands of families that have been devastated by gun homicide year after year after year for over a generation. And again, community firearm violence is concentrated in certain places as well. And I'm using these two graphics to help illustrate the ways that structural violence relates to community firearm violence, in particular in a city like Baltimore, Maryland. So these are two maps of Baltimore, Maryland. The map on the left is a map of redlining in Baltimore from the 1930s. The map on the right is a map of all homicide and non-fatal shooting locations from the years 2003 through 2017. You can see the intense concentration of firearm non-fatal shootings and homicides in Baltimore, particularly in the same areas that were redlined over 80 years ago. And the point to these maps is not to say that redlining caused this concentration. Redlining was just one of numerous intentionally exclusionary and racist policies that has contributed to those social determinants of health, decades of residential and economic segregation, concentrated disadvantage, high rates of unemployment and poverty and income inequality, high rates of criminal legal system contact and incarceration. And all of that helps to breed the conditions that contribute to high rates of violence. We also know that from research that there is great overlap between those who are involved in violence and those who have been victims of it due to overlapping geography, social and peer networks, and risk factors. And research by researchers at Northwestern University in Evanston, Illinois, found that being in the same social network of someone who was killed by homicide increases one's own individual homicide risk by up to 900%. But we know that that deaths are just a piece of the puzzle when it comes to community firearm violence. Um, Non-fatal firearm injuries have a, a case assault rate of about 20%. So we know that firearm assaults outnumber firearm deaths by up to 4 to 1. And this image on the right of the screen shows that this is from California Department of Public Health and showed that for about every 2,000 homicides in California, there were almost 11,000 hospitalizations and over 143,000 emergency department visits for violence-related incidents. So the impact of non-fatal injuries from community violence is by the numbers is even more widespread than the fatal injuries. And um, the impact of that level of violence, and the ripple of impacts, are hard to overstate because so many people are either devastated by the violent loss of a loved one or by the violent injury of a loved one or being exposed to knowing people who have been impacted by violence. And again, the psychological ex, sequelae of exposure to violence have been well documented. Um, these health effects are, again, not only felt by individuals who have been directly involved in violence, but also by individuals who witness or hear or learn about violence among family or peers within their neighborhoods. And they include traumatic stress symptoms like hypervigilance, hopelessness, emotional detachment, um, internalizing behaviors such as depression and anxiety, as well as externalizing behaviors such as aggression and substance misuse or abuse. So the personal nature and the social proximity of violence to those who have been exposed um, allows for person-centered approaches such as community violence intervention to really take hold and make a difference in interrupting those cycles of violence. And what is really critical about community violence intervention is that it involves two primary principles. The first is that it focuses on engaging individuals at greatest risk for violence involvement and their influential networks. And then it focuses on addressing the underlying risk or determinants of violence for that individual and their networks by increasing protective and healing factors that we know matter as it relates to reducing violence, promoting peace, promoting safety and health. And this approach of having community residents engage community to promote health is a well-documented health strategy for reaching historically marginalized and disenfranchised populations to help gain understanding about barriers to healthcare. It's been used to address a variety of health-related needs and outcomes, including for pregnant teens, for people living with AIDS or HIV, for individuals with substance use disorders, and also for violence prevention. And while these are not explicitly touted as social support health strategies, these types of community engagement efforts operate with the understanding that the individuals who are at high risk for negative health outcomes, who are marginalized and hard to reach, are also those most chronically alienated or disconnected from, and thus distrustful of traditional services and of support and safety and health. So what we know from the literature is that people who are at the center of violence, who have been harmed by violence, or who also engage in violence, um, have often been touched and underserved by the health systems, social services, by the criminal legal system, by schools, by the kinds of institutions in our society that we lean on for health and safety and well-being. Um, so that having these person-centered approaches, this personal level engagement of community residents to those people and their families that have been most chronically alienated and disconnected, um, is a critical way of engagement because they are not being engaged often through other services. And the value of CVI approaches was really made clear with the COVID-19 pandemic. Um, Law enforcement and city officials alike recognize that these strategies for utilizing outreach and violence interruption tactics were really important for addressing the spike in firearm violence that coincided with with the pandemic. And CVI personnel around the country reported working overtime to not only respond to violent incidents, but also but to also provide personal protective equipment, address rumors around the COVID-19 vaccines and the spread of COVID-19, provide basic assistance to food and water and household supplies for folks who were cut off from the usual supports. And we've seen record reductions in homicides and non-fatal shootings in 2025 across cities across the country. Here in California, numerous cities saw um, historic reductions in firearm homicide and firearm violence. And many city officials, police chiefs, police commissioners have credited these kinds of strategies, these person-centered community violence intervention strategies, as contributing substantially to those record reductions in violence. So the characteristics of the people who do this work is really important to how the work gets done. Um, CVI strategies employ trained frontline personnel who are from communities where violence is high, have that lived experience of knowing what it's like to be exposed to violence, to have lost um, family members, friends to violence, to understand the challenges that are associated with living in communities with high rates of violence. And these are specialists who are credible to those individuals at the highest risk of violence, and professionals who are trained to engage in trauma responsive ways that promote safety, well-being, and peace building. Building relationships with individuals can provide a bridge for identifying and addressing needs in order to help interrupt unhealthy or negative life trajectories. And these trained professionals understand that engagement with this population requires deep commitment and persistence because the individuals they're trying to reach, again, are among the most disenfranchised and disillusioned to believe that change is possible at the individual level or at the structural level, given their environments and the regularity with which violence occurs around them. And in that regard, the specialists can also serve as role models and examples of how individuals can change the course of their own lives because they've often walked the similar walk, experienced similar challenges, um, and are now operating as trained professionals to help interrupt others' cycles of violence. So there are a number of different community violence intervention strategies currently in operation in cities and states around the country. And in general, community violence intervention is referring to human-centered, non-punitive, and community-led strategies designed to interrupt the transmission of interpersonal violence by engaging those at highest risk through the provision of individually tailored support services. So we have strategies such as community or street outreach, which involves hiring violence intervention and prevention specialists who have existing relationships, relatable lived experiences, and credibility in their communities. And they meet people literally where they are, on porch stoops, on street corners and alleys, at barbershops, etc., to build authentic relationships and make offers of support to serve as peer mentors, as individuals who just are really willing and ready to just love on people, and show the importance of building that relationship in order to bridge opportunities such as job training assistance or employment opportunities. Another strategy is violence interruption, which involves having specialists who are specially trained in conflict mediation and violence de-escalation, dispute resolution to respond to and de-escalate potentially violent incidents. We have crisis response, which involves arriving on scenes where violence has occurred to help offer trauma-informed services or community supports to survivors or others exposed to violence, or to help navigate the criminal legal system response to violence. Um, and then you have hospital-based violence intervention programs, which I'm going to focus on for the rest of my talk. And these strategies provide intensive counseling, peer support, case management, and social services to patients recovering from gunshot wounds or other violent injuries. So, hospital-based violence intervention programs, or HVIPs, have proliferated nationwide as an evidence-based strategy to disrupt the cycles of violence by bridging short-term medical care inside hospitals with longer-term social care in the community. And these programs focus on engaging violently injured patients, often really concentrated on teens and young adults in the emergency department or at the hospital bedside who have survived gunshot, stabbing, or assaultive injuries. They utilize case managers known as violence intervention specialists or violence prevention professionals who provide extensive community-based services and outpatient care after a hospital discharge. They help individuals navigate the health system as well as connect to resources in the community that can provide victim services support, um, needs for housing, transportation, employment, and other basic needs. And these services really rely on relationship-centered mentoring, um, and that intensive case management and consistent engagement. And the goal of these programs is to prevent retaliatory violence by helping to alter those individuals' negative or unhealthy trajectories, but also to promote long-term healing, post-traumatic growth, and safety through connection to existing resources or natural supports within one's own community. We know that individuals who have been violently injured are at increased risk for future violence. One of the highest predictors of future violence is exposure to prior violence. Um, and so the ability of these programs to really wrap around individuals and provide case management and that peer support is a critical part of helping to reduce future injury or violence involvement. And we have one of these lovely programs here at UC Davis. So this is a photo of our current UC Davis Health Wraparound team. I believe at least one of these individuals, Chevis Johnson, is in the audience today. Um, but this is a team that is small yet incredibly mighty in supporting violently injured patients here at UC Davis. So just to give the criteria for the program and some overview of the wraparound program, the patient population uh, for enrollment criteria is being violently injured here at UC Davis Health between the ages of 13 and 30, and that community violence injury is being shot, stabbed, or violently assaulted. The objective aligns with other HVIPs in terms of the purpose is to facilitate holistic recovery for youth and young adults injured by violence and should to help them transition from being in the hospital to being supported long term by family, their networks, and community-based supports that exist in their local communities. And the program really focuses on in three particular areas: that intensive case management and mentoring, um, as well as providing trauma-focused mental health support. through licensed mental health clinicians and social worker support around that collaborates with the program, as well as peer support among others who have been violently injured, and having power of exposure events, allowing the individuals who have been violently injured to be exposed to new activities. They here at Wraparound, they've gone to soccer public games. They'll go bowling, go out to eat, and just have an opportunity to be engaged in community and exposed to new opportunities that um, help people see that there is more to life than what they may have previously been exposed to. And that intensive case management allows for the violence prevention professionals to deliver wraparound services, hence the name. And so the wraparound services are really individualized services for the people enrolled in the program. So if I'm enrolled in the program, I may need housing or financial assistance, but someone else may need legal services. Another person may need grief counseling, and the that intensive case management and those wraparound services allow for the violence prevention professionals to be the individual, to be that professional that walks alongside with the person who's been violently injured, connecting them to whatever kinds of services they need, that they see that they need for their own recovery and growth. So, I and my colleague, Dr. Nicole Kravitz-Wertz, also at the Centers for Violence Prevention, are part of the research and evaluation team for the Wraparound program. And we collaborated on the publication of the most recent end of grant period evaluation report that's highlighted here. So I just want to share some of what we found from that evaluation. Between October 1st of 2020 through June 30th of 2023, UC Davis Health treated over 570 violently injured patients who were between the ages of 13 to 26. And you've heard me, if you were listening, you heard me say the program currently is 13 to 30. We upped the age limit in 2024. Um, and of over 570 people who were injured, almost a quarter of the patients met additional inclusion criteria for the wraparound program. Of the 13 to 26-year-old violently injured patients who were treated at UC Davis Medical Center during that time period, the average age was about 20 and a half years old. Um, and over 85% of all program eligible violently injured patients were Black, Indigenous, or other people of color. They were 86% male and 14% female. And individuals with gunshot wounds represented about half of all violently injured patients who came into the UC Davis Medical Center, but nearly 70% of all patients eligible for the wraparound program. As part of the evaluation, we looked at both quantitative data and conducted some semi-structured interviews with clients to really understand what patients saw from um, who were enrolled in the program, what they saw as the reasons for saying yes to enrolling in the program because it is voluntary. What mattered to them in terms of their engagement through the course of the program, and how they saw um, their overall success in the program and once the program was over. So one of the questions that we asked was, what stood out to you that made you want to enroll in the program? And clients highlighted the importance of the connection that they felt with that violence prevention professional. Um, these are a few quotes from the qualitative interviews, and what this first client pointed out was the energy and personality of the violence prevention professional, how the professional was in the hospital, how they talked to the patient, really helped that patient gravitate to wanting to give the program a try. The same patient, when asked why they opted to enroll, said that the VPP's presence was really positive, and it didn't feel like the police had felt for them, which is very negative. So the violence prevention professional was there to help, and the client really felt that. A different client said that they felt the connection with the VPP who visited them at the bedside. They felt like this violence prevention professional was someone they could trust and talk to. And the violence prevention professional stayed connected with the person's mom because the mom didn't speak English. And so it helped that violence prevention professional was engaging not just the injured client, but also the caretaking parent. We also look at perceived social support because social support is one of those protective factors that matters in the aftermath of violence. What is the social support around people as it relates to their ability to lean on their network? Um, and social support for the clients involved in wraparound was classified as in the moderate range when patients were enrolled, um, and slightly higher by the end of the 12-month program enrollment. And you can see these are relatively small numbers, but they matter to us as we're thinking about making sure that social support definitely does not decrease over the course of the program, but can improve. And we noticed that they were lower among average, also among clients who subsequently were lost to follow-up. So when clients dropped from the program or the cases were closed due to non-responsiveness, we saw among those individuals who didn't persist through the program, they had lower social support services, excuse me, social support scores to start with. So this area of social support is really one that matters for both program engagement and, as I said, for violence recovery, emotional, psychological recovery. In the qualitative interviews, we explored this role of social support in the client's understanding of their own healing journeys. And several clients mentioned that the violence prevention professionals had become part of their social circle. So you see in these quotes, the violence prevention professional got became part of the social circle. Another client said that the VPP had been there for me, almost immediately after this client was shot. And another client said, I didn't think that, the VPP would always be there. Um, I thought that there was a lot of other people, other things going on, which there probably is, but it just made me think that it wasn't going to be consistent. But then it turned out it was really consistent. So it kept me on my toes. And this really speaks to that relationship of engagement and the consistency of showing up for people who have been, let down by other systems that we lean on, typically lean on, or support networks that we think should be there, particularly in the aftermath of violence and something so traumatic happening to people. Um, and then we asked, how did you at all, if at all, change over the course of the program? And one client said, I think I changed a lot. Wraparound opened my eyes to a lot of things. Um, you have to, as bad as the altercation that I went through and me experiencing the things that I experienced, I think I learned that sometimes you just have to be the bigger person, and you got to walk away as bad as you want to say things to people and you want to fight, sometimes it's not that good of an idea. You should just be the bigger person and walk away, as you may think that make, excuse me, and as you may think that make you a punk or scary or something. Sometimes you just have too much to lose to put yourself in that situation. And I like this quote because it helps to illuminate how being engaged with the violence prevention professionals as part of Wraparound helped to transform this person's um, understanding of how to respond in situations that might otherwise lead to violence. And this is exactly um, the point of person-centered approaches to community violence. It's to connect with someone, um, connect with individuals at the highest risk of violence in ways that help them see um, that they can alter their trajectories and that they have the support to do so with the professionals in the program. So I will wrap up by just sort of, pointing out what can those of you who are scholars, CHPR scholars on the call, or watching the recording, and other healthcare providers, what can you do to help prevent community violence? Well, for one, advocating for both the research and practice of hospital-based violence intervention programs and other community violence intervention strategies that help to address social and structural determinants of violence. Um, these programs and the research is often precariously funded, and we see in the violence intervention and prevention research how critical these kinds of strategies are for the recovery of people who have been violently injured or who have lost family or loved ones to violence. And so it's really critical that these kinds of strategies persist and grow and are strengthened. Um, if you are working in the health system and are a provider, um, identifying the crisis support services and referrals available to violently injured patients, connecting with the wraparound program and other the support collaborations, the social workers, the care center, the trauma recovery center, the other resources within the hospital, but also outside of the hospital that are available for people who have been violently injured or otherwise impacted by trauma. Um, you can be trained on and actively practice trauma responsive care and cultural humility to better support patients, especially those who have been violently injured as they navigate the health system. Um, and paying, particular attention uh, to mitigate biases toward patients. Um, we often hear among those who have been violently injured that they experience perceived or real bias in the healthcare during and during their stays in the health system because of their violent injury. And I think it's important that the providers recognize that, though many people may have preconceived notions about patients who come in with violent injuries, as one of our wraparound clients told her case manager, no one wakes up and asks to be shot that day. And so it's really important to recognize and catch where biases may be implicitly or explicitly expressed for people and their families that are experiencing such a traumatic experience as violence. Um, and then also, more broadly, supporting local, state, and federal policies that urgently invest resources into building and maintaining healthy and stable communities, which will inevitably create safer communities as well. And with that, I thank you for your attention, and I welcome questions.
Such a wonderful talk. Thank you so much, Dr. Buggs. I'm going to pause here and see if people have questions into the chat or want to raise their hand to ask questions. Um, I do have one to get us started, but please do start writing in chat or raise your hand. I promise I will call on you. Um, I recognize how hard this work must be to fund, and that was one of your calls to action. I was curious, could you talk more about how the current wraparound program here at UC Davis Health is funded and sort of what that looks like internally?
I lost my mute button. Yes. Thank you for the question. So the wraparound program has been exclusively grant funded and has been up until it is currently still funded by the California Violence Intervention and Prevention Grant Program, which is a state program for community violence intervention strategies. Um, the program this year was applications for renewal for the program. And the state got unprecedented demand for those funds and unfortunately funded only a very small percentage of all applicants for the program. And the hospital-based violence intervention program was not selected for grant renewal. So the program is currently at jeopardy of being ended as of June 30th of this year. There are active efforts happening to secure funding for the program. But
Yeah.
yeah, that is a real challenge and a real concern.
Yeah, such a real concern. So, yeah, I mean, I think for everyone on the call, if there are other granting opportunities or other partners, I think I would love to, make sure there's more long-term and sustained funding for this program. So it's good to know on this more public seminar, the state of it, so we can continue to advocate for it.
And thank you.
Yeah,
I just want to say, yeah, if anybody would like to connect with me offline, my email is here. Um,
yeah,
yes, because we are actively and fervently pushing for this to continue.
yeah, that's wonderful. Yeah, so I'll think too about anything on my end that I could advocate for or think through because I think this research is just so amazing. The program is amazing, and then the outcomes are truly amazing. So on both fronts. And so I have one more question, but I see I want to see. Actually, I'm going to ask the question from the chat because it's a great question from Dr. Hodge. Dr. Buggs, do you teach any classes or are there other opportunities he's asking you for people to learn more, to be more engaged in this work? And I already know the answer to that, but maybe you could talk more about it.
Thank you, Dr. Hodge, for the question. Yes, my colleague, Dr. Nicole Kravitz-Wertz, and I co-teach in winter quarter. So we are actually ending tomorrow, our last class session for this academic year. But we teach a class on mixed method approaches to structural and community violence. And we talk about community violence intervention strategies in the program. We have had our wraparound violence prevention professionals come and guest lecture in the class. I see Chevis Johnson on now. Chevis has been a key presenter for that class and a leader in this work. So yes, I do teach and look forward to teaching again next academic year for anybody interested. It's in the Public Health Sciences department.
And Jeff, do you want to come off mute and ask your next question too? I think it's a great follow-up.
Dr. Buggs, thank you so much for your talk. Really enjoyed hearing about it. You mentioned that you used mixed methods, and for some of the students, I think they might feel like, learning about one is difficult enough. Mixed method sounds like two, but you might, again, there's some advantage that researchers can get from being able to study things in more than just one way. And I wondered if, in particular, for this context, you could explain why maybe it's worth it to learn a little bit more methods to be able to do more good with our work.
Absolutely. Thank you for that question. So with the wraparound program evaluation, for example, we had the numbers to show how many people were enrolled, how many people, or how many people were eligible, how many people enrolled, how many people completed the program. You saw the perceived social support numbers. We also do screening for post-traumatic stress disorder at the beginning and then over the course of the enrollment in the program. Um, and what we found is that the numbers give us only a piece of the story. Understanding how clients engaged with the wraparound program allowed us to see what do we need to continue, where do we need to lean in, what really mattered, the findings that actually, we talk about it as a program, wraparound program, but for client engagement, they didn't feel a formal program. They felt a connection with somebody who continued to show up, who continued to demonstrate that they cared for this person, they were showing love to this person. They wanted to help, they had resources to help. We wouldn't have gotten that if we only focused on the numbers. Understanding what success looks like for the clients is another question that we asked. And what they saw as success was really meeting their own life goals. They didn't say, I don't want to be re-injured violently, or I don't want to, engage in retaliatory violence. That like those are the ways that we academics may think about, some of the value of this program. But that's not what they saw as success. They saw success as them being able to continue on a trajectory in life that felt good and positive, and safe and healthy for them. And so yeah, like those are just a couple of examples of how um, the numbers can tell you, you know, if people enrolled, if people completed, if people dropped out. Um, but the questions, the qualitative data tells you the why and the how, and really gets at the substantive experiences for the people. And we would have loved to engage also those who were lost to follow-up. Similarly, because we would want to be able to find out, what didn't like why did they not stay engaged or enrolled? But that's it's difficult to do in a healthcare setting. We didn't collect information from people who said they didn't want to continue to be connected. But the qualitative data really helps you get at the why and the how. It's really critical, I think. Yes, it's hard. Yes, it can be more challenging. It can be more time consuming, but it really, really helps you have a fuller understanding of a program or a strategy that you're looking to understand. And if I may, I do see both Chevist and Dr. Ian Brown, who are associated with the program, as well as Amelia Lawless, who is a social worker, and partner with the wraparound program. So I just want to acknowledge them, thank them for their hard work and dedication to wraparound program. And if they have anything to offer, I would welcome their engagement here too.
Yeah, more than welcome for any of you to chime in. I actually see Dr. Brown wrote in a question, I think, into the chat. So maybe you can answer it and he can follow up, which is, what about the buy-in from the clinical side? Can you talk about what that looked like in this specific program and what the importance of that is?
Yes, that's a great question. Thank you, Dr. Brown. So what we've seen, the wraparound program has really done a great job of showing up in the hospital, and providing education to clinicians and healthcare providers about the existence of the program, the criteria of the program, and why the program matters. And as the program has continued to operate over years, and increasingly healthcare providers have seen how the violence prevention professionals can step in. Healthcare providers they are there to treat a patient and move on to the next patient. And the violence prevention professionals provide that empathetic, trauma responsive care for clients. They can connect them to resources the healthcare providers may want to connect to, but may not know what's available, may not have the time and energy, the time and the capacity to engage. And so that presence of the violence prevention professionals in the wraparound program has really allowed clinicians to see the benefit of the program. Um, they also have been able to, I think, understand, I talked a little bit about some of the perceived or real biases that clients can feel who have been violently injured. And the wraparound program is an advocate for violently injured patients, and so they can see that there is this program that is advocating on behalf of violently injured patients and ensuring, insisting, demanding that those patients and clients get the care that they need. I think the clinicians, we're actually in the process of doing some interviews with some of the clinicians and healthcare providers associated with the wraparound program. And some of the early responses that we've gotten is just the importance of that connection that wraparound provides for the client to the hospital, for the client to the community, for the hospital to the community. Like it really helps to illuminate that UC Davis Health cares about violently injured patients, and is providing support to make sure that those individuals get the support and the recovery healing that they need.
Such a great answer. I love that. Like it's like so many layers. And the program has so many layers, and the ambassadors and the experts have so many layers dealing with the clients. And I know we're almost at time because I have other questions, and maybe I'll follow up with you offline. I just think it's such a great example of such a multifaceted intervention program and how it's addressing structural and like so many different levels of both interventions and also support. So I think it's a great example both for violence prevention, but also for many other health promotion and health, engagement strategies. So just really grateful for you sharing with us how it was structured and sort of how you evaluate it, so that maybe we can all work more on programs like this.
Thank you very
Really
much.
appreciate you.
Yeah, thank you.
Really
And
appreciate you.
I see that Maya Lawless came off mute. I didn't know if she
Yeah, go for
wanted to
it.
weigh in our last couple minutes.
Well, I just wanted to
Yeah, go for
extend
it.
appreciation for the program. It's been really, we can't always talk about specifics, but recently there was a really high profile case that had gone on for some time, and um, the decedent's family contacted us to express their sincere appreciation for kind of the long-term follow-up. And this person was really um, di like separated from many social supports along the way for a lot of really, really good reasons. And TRC was the root and the anchor while this person was unable to engage with their family. And so it's just I think the thing that this talk made me think about more is how do we make sure, especially around the funding concerns, is how do we make sure that these stories are heard in a way that supports patient privacy, but also in a way that really highlights the the need for programs like this, and especially at a level one trauma center where we are seeing patients from all over. So really appreciate all the hard work of Chev and Dr. Buggs and Dr. Brown and everyone else who has contributed to just keeping things moving. And we are happy to help from wherever we can as social work.
Thank you.
I think that's a wonderful way to conclude. I know you're so gracious. If people want to reach out, your email is still up on the slide to reach out for more. And just, I feel like we learned a lot today. So I really want to thank all of you for coming and sharing this amazing work with us. I hope you have a great afternoon, and hope to see you all soon.
Thank you so much.
Thanks.